So thank you so much. I hope my slides are visible.
Is okay.
Yeah, yeah. So unfortunately, I'm not there in person, and I really missing Varanasi. And I think brilliant effort by Alok and wonderful lecture by Dr. Rishi Sethi. So this is now a time for a CSP versus CRT kind of discussion. And we all are aware that connection system pacing in last couple of years have really made a huge noise. And in terms of relevance and adoption, it is second only to transcatheter aortic valve replacement in the field of cardiology. So we have seen TAVR almost replacing surgical aortic valve. The same way probably CSP is going to replace CRT. And let's have a discussion on that. These are my disclosures. I am a proctor for CID devices and MICRA, and I accept grants and honorariums. So let's now come to connection system pacing. And we all are aware, if you kind of engage connection system, whichever way you do, whether it is stylus driven or a kind of a luminous lead, you get a QRS something like that if you hit the right spot and engage the connection system, a very narrow QRS and almost normal, normal looking QRS, and there will be a zero kind of pacing induced desynchrony, and that's what give you the final edge and the benefit. So these are some of the examples. If you hit the right RV septum, deep septum, LV septum, and the left bundle branch, area pacing, what all kind of configuration of ECGs you can get. So ECG which is narrow with a LVAT of less than 70 and V1, V6 RV peak time, RV peak time less than 35 or 33 gives us a reasonably clear idea that you have engaged the bundle branch and connection system, and your future outcome can be different and better. And the kind of ECG axis you will get is it depends on where you are hitting the target, whether you are hitting the left bundle area or you are hitting the left posterior fascicle or anterior fascicle. So I will not go in detail. I will just give you a glimpse and some evidence about this connection system pacing. So this is the most widely used hardware. This is a 315 sheet which is non-deflectable, which has got two curves, and this is a luminless 3830 lead of Medtronic. And this, I think 80 to 90% of CSP is being done now is from Medtronic, although Boston, Abbott and Biotronic, they are also now in field with stylus driven leads. So this is how we do. We go in RAO, we see, we run an imaginary line from his to apex and 2 to 3 centimeter down, we target, and then we go to LAO and we see that the sheet which is there with the lead is perpendicular to the septum, and in RAO the lead movements will be towards your left shoulder, so towards the patient shoulder, left shoulder. So this is and then with the electrical mapping, you can be kind of 100% sure and confirm that you are hitting the CSP. So while you go in, you have to give a little quicker rotations, and you can see in fluoroscopy how much advanced you are inside the septum, and the electrical parameters can also tell you. So you can see here a V1, W pattern V1, and when once you start going in, the terminal, the notch starts going up, and then you get a R wave in V1, and the QRS becomes narrow. Then we measure the RV peak time in lateral leads and V1, and then you can make out whether you have engaged the left bundle or not. So I will tell you what the criteria and all, and then finally the slitting, and then you are out with the lead in, and then you can close it with the device inside. So kind of ECG you get, or electrocardiogram you get, depends where you are hitting. So he's recording R wave or R dash, R prime in V1 is kind of 100% surety that you have engaged the left bundle branch or the connection system. It's not entirely true when because sometimes when you are hitting the deep septal, high voltage, you can still engage and you can have a terminal R. But in those situations, you can have a kind of QRS and LVAT more than 70 milliseconds, maybe towards 90 or 100. and also the V6 V1 interval will be lesser. So I will not go. These are some deep electrophysiological measurements. I will not go in detail, but I will give you some evidence. And just before that, just to confirm whether we have hit the conducting system or not. So you can see the potentials. If you are in his bundle potentials can be seen. If you are hitting the left bundle potentials can be seen 25 to 30 milliseconds before the R wave, and the stim to QRS depends on where. If you are at left bundle, it should be from left bundle to V, it should be equal to that, or his bundle to HV. So and the PS QRS morphology will be kind of similar to baseline with the R wave in V1, and then correction of bundle branch blocks if they are there from before. Notching and slurs will be conspicuously absent or very minimal, and then R with peak time, which we have discussed. So let me go through quickly to some cases, and these are the sites where you hit and and see whether you are getting the parameters which correspond to engagement of CSP or not. So this was a gentleman who was only 42 years old. He was having dilated cardiomyopathy with ejection fraction of only 28%, and QRS was 180 milliseconds. So very wide QRS, very young patient, DCM. So I wanted to give you the best possible QRS of, in this scenario, because he still have so many years left with him. If we provide a good engagement and good QRS narrowing, he can have a normal ejection fraction because it's a plain DCM. So we went with optimized CRT. You can see here a left coronary sinus lead and a left bundle pacing, and then you can see what kind of ECG we got. So if I don't say that it was a pacing ECG or paced ECG, will pass it as a normal kind of ECG. Such a kind of fusion you get when you engage both optimized CRT. So this is what has been reflected in most of the studies, and this is a kind of 14 studies meta-analysis reveals that once you engage HIS, you get the maximum fusion and the narrowest QRS, and as compared to BIV. So HIS and optimized CRT gives you the maximum possible shortening of the QRS, followed by left bundle branch, followed by the normal BIV pacing, conventional BIV pacing which we do. So these are initial studies with HIS CRTs, and these studies give us an idea that HIS CRT can give you a QRS which can be narrower than BIV, and the ejection fraction improvement can be better than conventional BIV, and also the LV and systolic volume remodeling, reverse remodeling can be more favored with connection system pacing. This was the randomized control trial from Chinese group, Dr. Huang, CRT versus CSP, left bundle branch pacing, and it showed very clearly that the ejection fraction improvement, LVEF response, and LV and systolic volume was more favorably differed in cases of CSP, left bundle branch pacing, than BIV pacing. This was also initial studies from Dr. Vijayaraman, which showed the feasibility that in lieu of CRT it can be done. It was done in more than 300 cases with ejection fraction less than 50%. And these studies are pivotal in having the HRS endorsement for CSP, which I will show you what evidence we have and what recommendations we have. So this was the initial study from Dr. Vijayaraman showing 85% success rate in attempted cases, and it was feasible and reducing the QRS and giving us good ejection fraction. Again, this is from Chinese study, prospective multi-center observational study showing that BIV and LBB CRT, the LBB CRT gave us more narrowing of QRS, especially when they were using optimized CRT. So this was ejection fraction baseline, and after 6 months, we can appreciate those were better fusion with LOT CRT and better results than normal BIV. And this was a very large study from the left LBB collaborative group. Dr. Sanbuga also contributed a lot of cases here, and here it was more than 1,000 patients, and which clearly showed freedom from death or heart failure hospitalization was also significantly different when CSP was used in lieu of bilateral pacing. So we are gaining evidence in terms of observational studies, in terms of registry data on terms of meta-analysis, and a few RCTs as well. There's another place where the left bundle pacing or CSP can be more productive is a AF situation where we are going for see this patient with atrial fibrillation with a poor LV function and a normal coronaries, and you see the ECG, the echo, which was dilated heart and dilated left atrium, persistent kind of AF. So there was no point going for a AF ablation, so we went for AV junction ablation in the CRT. So there was a lot CRT done after AV junction ablation. This kind of ECG which we got pace at 90 per minute. As we all know, if you do AV node ablation, junction ablation, you have to pace the heart with 90 heart rate for 2 to 3 months, and you see the narrowing of the QRS, and patient definitely improved in 3 months time. And this is also one area when you are going for a node ablation and a pacing system. LB pacing is more preferred over IV pacing, and we have many evidences right from his bundle to left bundle pacing. This was a case which we published, 68-year-old lady, left bundle branch block with intermittent CHV and ejection fraction of 45%, and this was the ECG. So with this kind of LBB ejection fraction 45%, always good to give a CSP or a narrow QRS in these patients, recruitment of bundle branch, and we did it, and the patient had a severe scoliosis of spine. You can see here. So this was amongst our initial cases, and it was a demonstration that even in a very abnormal anatomy like a severe scoliosis of spine also it can be done, and we published at a case report. And the third scenario where we get maximum benefit is lot or hot CRT, which we have ample of evidence that the QRS narrowing and diffusion is best with these kind of scenarios. And this was one patient who had a RBB and a left axis with a QRS something like 116, 117, not qualifying for or maybe 100, reaching 120, and we were very not clear how CRT will help because there is no such evidence. And then we did a lot CRT. You can see the kind of narrowing with the lot CRT, and in fact the patient improved. And these are our case series published in Heart Failure Journal of India about lot CRT in refractory heart failure patients with non-LBB morphology. So these are scenarios where CSP has proven to be more effective, and even in normal conventional indications, we are getting evidence that CSP can probably outsmart CRT. So and that's all with all this evidence. 2023 HRS, APHRS, LHRS guideline will clearly endorse those patients who have a high requirement of pacing, more than rather 20% pacing. If you feel that the patient will have a kind of is in CHB and it will require a more than 20% time pacing with ejection fraction less than 50%, it's always preferable to go for a CPP. CPP means this is a physiological pacing. Physiological pacing involves a CRT as well as a connection system pacing. So cardiac physiological pacing is a new term given to this synchronized pacing, the entire kind of combining a CRT as well as CSP. So CSP can be offered with class 2 indication in those patients with less than 50% ejection fraction who we feel that percentage requirement of pacing, RV pacing is more than 20%. And still we don't have a clear-cut guideline with less than 35% ejection fraction. CRT is still the way to go as per the guidelines, but with the evidence which are pouring in. You see here the RCTs with the CRTs numbering thousands of patients, but with the CSP it's still in hundreds. So maybe a couple of years more, and once we get more RCT evidence showing CSP giving better results than CRT, better fusion, which is already been seen in initial studies, probably the things will change in favor of CSP versus CRT. So with this I conclude. I think I have given message that the time has come to get an idea and change the practice towards CPP, and connection system pacing is probably the normal way of pacemaker in coming times. Thank you so much for patient hearing.
Thank you, Dr. Dilip, for your excellent talk. And I ask one question like, what is there any reverse remodeling data with the CSP in heart failure?
We have ample of reverse remodeling data. As we showed, as I showed in my presentation, multiple evidence from Dr. Vijay from Dr. Chinese group, also from European group, the Milo study. So there is a better reduction of LV systolic volume and more improvement in ejection fraction has already been seen. We have a lot of observational studies and registry data, meta-analysis, but we are lacking in RCTs as far as CRT versus CSP is concerned. Initial RCTs of around 100 patients have shown in favor of CSP, but we still need to have more data. But less than 50% ejection fraction, you are open to use either of a CSP or a CRT. Yeah.
How many percentage reductions seen in the with the systolic volume and or end-diastolic volume reductions?
Yeah, so most of the studies have shown 11 to 15% reduction. So some of these cases have shown more, some less, like mean of 14 to 15% is a LV systolic volume reduction.
Okay, thank you.
Now I will invite Dr. J.S. Mehwal sir. Dr. J.S. Mehwal sir needs no introduction. He is currently the Executive Director and Head Cardiovascular Surgery, Heart Transplantation and VAD program at Fortis Escort Health Institute.